walking sticks. Not a bad idea for any of us to have one of those handy. Even if you just have to cross a flooded street after a good rain in Houston, nice to poke that walking stick ahead and make sure you're not about to be swallowed by a Houston pothole. We'll move now to a topic with which only a few of us are comfortable, very few, and that's hospice care. I had to learn all about hospice during my mother's final weeks of life and went into it totally uneducated. I had no idea. To help with that education for you guys, I will welcome into 50 Plus Dr. Jeff Lee, a board-certified geriatric specialist since 1988. You don't look that old, Doc.
Thank you.
Yeah, thanks for being here. I appreciate it. Also currently with Crossroads Hospice. You sent me by email a brief history of hospice, and that kind of fascinated me because I'd never heard it from that perspective. Where did this start?
Started in the late 1880s in England, primarily aimed at cancer patients at end of life.
That's when they called cancer, what they call that? Consumption? Have you heard
consumption is actually tuberculosis.
Boy, have I got a phone call to make then to a guy who's been saying that forever and ever. We spoke earlier in the show with Dr. John Halpin about how and when family members should start making medical decisions for their loved ones. Eventually, though, as was my case, we have to decide that it's time for hospice care, and actually that's the person's doctor who helps with that call, right?
That's right. Primary care doctors are our primary referral for our hospice appropriate patient.
So once you advise a family that mom or dad should go into hospice care, and that's a pretty big shock, what next? Does your office provide numbers to call? How do they get from a doctor's office to a hospice provider?
Generally, hospice is such a new concept to family members. They need a little bit of information visit from one of our we call them hospice care consultants.
Okay.
They get a visitation to say, this is what hospice is, this is what hospice can do for you, here's how it's paid, here are our goals. Just discuss the basic mechanical concepts of hospice to see if that's going to work with the family first.
Okay.
Once they decide that, hey, I think this is what we were looking for, then we send out our nurse who does an admission and takes down all of the medical data, and then I follow up the next day for a physician visit and do a history and physical exam.
What sort of checklist are you running on that patient, Dr. Lee, that says, okay, this indeed is a candidate for hospice? I concur. I agree with the attending physician's diagnosis that we're just about to the end. What are you looking for there?
I mean, that is probably the number one question that a hospice medical director has to address. Is the patient who was just referred to us, who was just admitted, truly representative of a hospice appropriate condition and a diagnosis and meets the criteria? So the medical director goes out, looks at primarily what diagnosis do you have that makes you appropriate. Obviously, the easy ones are cancer with metastasis, and the oncologist says, I just can't treat you anymore, you need comfort care. The more difficult ones would be like heart disease, respiratory, liver, kidney disease, where the prognosis is just a little bit harder to predict. But the number one criteria for hospice appropriateness is, in the opinion of a physician, primary care or medical director, that if the disease process continues in its natural course, that the life expectancy probably is 6 months or less.
Right.
And that's the big question that I have to address when I go out and see the patient that my hospice care consultant and my nurse, admissions nurse have told me, yes, we believe it's appropriate for us. Now, of course, we've had conversations about that before I go out, and so pretty much they're 99% on the money.
Customary for hospice groups representatives to visit quickly, but once they're in the process, then how often is that caregiver going to come back and check on mom or dad or whoever it is?
Another excellent question. By regulation, my hospice nurse, my RN, will visit once a week regardless of the diagnosis. If the patient is particularly fragile, not doing well, the visits can be anywhere from daily to every other day to every third day. But in addition to the hospice nurse, visitations are made by our hospice aide to help in bathing and hygiene, by our social worker, by our chaplain, and we have volunteers. So multiple visits by multiple disciplines in addition to the medical director and the nurse.
And once the assessment is made and they're in hospice care, if I were dealing with my mom and someone had just been there yesterday, but I thought she had changed or there was something she wasn't getting that she needed, all we have to do is pick up a phone and call the hospice provider and they will send somebody to check, right?
Absolutely. You call your primary care nurse, we call her the case manager,
Right.
and if she can't answer it simply by a telephone call, she will go out and make a visit, and particularly, you said the critical word, change in condition.
Mm-hmm.
We always visit for change in conditions when the family is concerned. If my nurse goes out and says, oh, I don't understand what's going on, I think I better have Dr. Lee come out and give us an opinion, then I come right behind the nurse.
A lot of hospice care, when you talk about it this way, and when I'm thinking it through with my mom and whatnot, a lot of it's always about the comfort of that patient who's been told they've got 6 months to get their affairs in order, and that's about it. But it's also for the comfort of the family too, to have that phone number in their hip pocket and understand that is help. It's not somebody who's going to put you on hold. It's not somebody who tells you you've got to come back in 2 weeks and schedule an appointment and all that. It's right now help for when you really most desperately need it, isn't it?
Absolutely, and I think that is one of these beautiful points of hospice. When you feel that you have a problem with your family member and they need to be seen, you have the hospice nurse come out 24/7. We have nighttime call also, and this is in deference to, oh my goodness, mom's not doing well, I'd better call the EMTs, and then that initiates an emergency room visit. And by definition, at end of life, you don't want to be going back and forth to the emergency room
Certainly
just for an
not.
evaluation.
Yeah, that's hard enough. It's hard enough to be in that stage of life, let alone having rides back and forth.
Absolutely.
Hustled onto a gurney and hauled everywhere. No, I don't think anybody deserves that. Once it's time, it's really at that point there's a realization that the family has to come to as well. How do you deal with that? How do you tell people that mom or dad is not going to make it another 6 months, most likely, and comfort them in knowing that person is going to be as best taken care of as possible till that time comes?
Well, it's another. You've got all the great questions.
I just made that one up.
You're like Ed McMahon.
I'm thinking ahead. No, thank you.
In general, family members have come to that point where they've said for their loved one, mom, dad, grandma, spouse, enough is enough. We do not
Right.
want to go back to the hospital. We don't want that aggressive care. All that happens is mom or dad gets sicker when we go to the hospital and comes back weaker.
Yeah.
Enough is enough, Dr. Lee. I want the hospice nurse to come out. I want mom and dad to be treated at home, not in the emergency room. And we have come to the emotional point where quality of life is much more important than the quantity of the extension of that life.
Yeah, that's a very good point. I've learned also from my reading and from experience that if, say, the patient is at home and might be better served to be in a facility somewhere, that they can be moved on hospice's dime, right?
Absolutely. We really do feel that our hospice patients, our geriatric patients would love to be at home at time of death. But sometimes that's just not practical. The ability of family members to handle these end-of-life issues is limited. So from home, we can go to assisted living. From assisted living, we could step down to a nursing home. We have a great number of patients who live in memory care for Alzheimer's disease and other dementias. those facilities have what we call age in place. If you are
Time out, end of life, and end of show.